This is a case that was done at the VA Minneapolis Medical Center. Dr. Santiago Garcia was the one who did this, and this is our team. Rosemary Kelly is the surgeon, and other interventionists there. So this is a patient who is a 77-year-old with a NOHA class 3, and I'm just giving all the frailty score and MOCA scores here for you. She had normal creatinine. Her clinical history is significant for her. The ones that I put down here are more relevant than cataracts, I feel. So CKD, diabetes, AF, on anticoagulation, PAD, and coronary disease, EF of 35–40%. And she was deemed to be an intermediate surgical risk from the STS score calculation. These are echo findings. Her valve area was 0.8, peak gradient almost 69, with a mean gradient of 42. She did have mild AI. It appears a little more when you look at the images. And this is the short axis view, and then the 3-chamber view. Seems a little bit more of a AI right there. EKG just AFib. So no pacemaker, no AVC, not on immunosuppression. Otherwise, just concomitant for the AFib we talked about. She does have known coronary disease and never had a prior revascularization. And just a coronary angiogram before the procedure. Her LAD appeared to have some narrowing right there, but the RCA is CTO. And we did FFR of LAD was 0.84, and then we bit closure. So you can see you already start noticing, and she has no history of peripheral arterial disease, but all her vessel anatomy looking not very favorable for getting a transfemoral TAVR. So TAVR measurements, area of 590 with a perimeter of 89. And she had good coronary height, greater than 10 millimeters on the 2 views that I'm showing. And short axis view, her dimensions here. So you can see the right iliofemoral system. This is the common that I'm showing. You see a lot of calcification. The narrow diameter is 3.6 cross 7. The left side is 3.3 cross 6. And we evaluated the left subclavian artery for access because of the bad peripheral vascular disease. I was found to have greater than 6 millimeter on the left side. That's at axillary dimensions 9 cross 10 with no calcium. There's an angle from approaching from the subclavian artery. There's the overall diameters here, annular size 590. Coronary heights are okay, and the dimensions of external iliac on the right and left both are not favorable. So this is just a slide on using alternate axis. You know, we've been used to the femoral axis, but other axis really, from 2012 to 2014, you can see less than 10%. Transapical definitely went up after we started planning transapical TAVRs from the third quartile of 2012. So we chose percutaneous left axillary approach, and we chose the 29 millimeter Edwards sapien valve for this. Just the anatomy, so we all know this is a teres minor muscle, so the brachial artery becomes your axillary artery, and this complete part, it's going to be your axillary, and then becomes first strip, it becomes subclavian artery, and usually the preferred axis site is going to be right there, and you measure dimensions, and we got all these dimensions greater than 6 millimeter on. So this is our 4 French from the groin shooting your subclavian artery, and we're measuring. There's a micropuncture wire for the safety wire trying to access at the site where we saw. And just the sheath advancement. So this is the team of the surgeons and interventionists doing it. So first we deployed 2 perclose devices and exchanged with the Safari wire, a standard procedure like everyday procedure. And that's our implant angle here. I deployed the valve. I was 80-20, almost 90-10 or 80-20, I would say. Good implant and rapid pacing. No AI was noted on TE as well as the angiographic pictures that we got. I just wanted to open this and see what do you think of what we're dealing with here. Is it considered perforation? Could be aneurysm. Sure. Contained perf. Yeah, I thought contained perf too. And so initially what we did was we had to go with the balloon from below and used a 9 atmosphere balloon, so it was trying to hold pressure for some time, but still there was bleeding. So at this point, we decided to use an endovascular approach to use a atrial stent. So it was almost close to 38 millimeter stent. So 9 cross 38 stent was used. It's an atrial stent that we're trying to deploy here. And we positioned it, confirmed with angiogram, and post-deployment, this is our angiographic picture. So you can see this margin, the vessels intercostal are probably not compromised, and this vessel is also looking okay. So overall, we felt happy with the result that we got after we deployed the endovascular stent. So post-procedure, we got this image, showed a pseudoaneurysm with a narrow neck right there. Sorry, I should have inverted the image. And then this is a 1-month follow-up for pseudoaneurysm. We felt comfortable with the conservative approach because of the narrow neck, and discussed with vascular surgery, and they all agreed with the follow-up. And you can see subclavian artery and vein, and it's a contained thing. There's no further flow after a month. So endovascular approach is being more commonly used, and you can see in some studies showing a vascular closure device are usually successful, but if they fail, treating with endovascular graft implant has been shown to be successful with rates of almost 80 to 100% here in a few studies. And the long-term patency rate has been above 70 to 90%. There's a little difference in anatomy between a subclavian and femoral artery. Subclavian has a lot of fibroelastic medial tissue compared to femoral artery with a lot of smooth muscle and media. Just something to keep in mind when we use these arteries for access. Well, with that, I'll stop and I'll be open for questions. Thank you.
So are you implying that with the axillary approach, incidence of pseudoaneurysm is higher and femoral approach than typically?
Yes, that's what I was reading about a few studies, and it says because you don't have a lot of smooth muscles to give build resistance to avoid complications and perforation, and the vessel wall anatomy is different, so it is a little more riskier to do it at subclavian than your femoral vessels.
Would there be an advantage to give protamine for the axillary cases then to help in terms of sealing up and avoiding the pseudoaneurysm?
I think not a bad idea, but I'm not an expert definitely for commenting on. I'm sorry.
And part of the challenge in those cases is that the data is lacking about the outcome of covered stents and subclavians.
Sure.
I mean, for the reason that you mentioned, it's a very fragile artery. We've all adventured there and regretted it. What is the data? What is the data of long-term data about a subclavian stent is covered subclavian stent is lacking, and it seems that the location is a little bit distal, but as you go in the the chest cage a little bit more proximal, then the risk of thrombosis will become significantly higher.
Okay, this is late. Yeah, I mean here it was an easy thing for us after deployment. The angle was right, and
I may have missed it in your presentation, but why did you guys choose axillary access? Was this a true subclavian access? What was the issue? Was there stenosis somewhere, or why did you go in that very dangerous area on purpose?
I mean
Why did you choose axillary and instead of really subclavian access, the traditional one, closer to the?
This allows
It was more distal, I
percutaneous
thought.
approach without cut down.
so we're just doing percutaneous approach. So just this is more favorable from what I was reading. For a perc approach, that's more favorable than going cut down axillary.
Pictures, you were a little more distal in the subclavian area, and you call it an axillary access. So I was just wondering, were there no options closer, or does anybody? Am I just wrong? It just looked a little more distal in the distal part of the artery, proximal, I guess, proximal to the vessel.
So it appeared that you punctured close to where your A marker is, correct? Or
Right there.
Looks a little, maybe I'm wrong.
A little closer actually, here somewhere. Between the two segments is the 1 and 2. Yeah. It seems a little different in this view. Just a little rotated, I feel, because the clavicle angle is also different. Yeah.
You prevented, obviously, you solved a very complicated vascular complication, and hopefully over the long run should do relatively well. Obviously, we don't know what the utilization of those stents that was recently mentioned.
Right. We had a follow-up for this patient. Actually came back after a year for another follow-up, but there's no further complications, no signs of any ischemia going on. So hopefully it's patent. And
what do you think the advantage of doing it all percutaneous
It was a surgical team decision, and they combinedly wanted to try the approach, so it's combined with surgeons.
Advantage or disadvantage?
I don't know, just I can think of the healing part, and maybe just getting it more percutaneous will help the patient recover early. So just wanted to try the new approach and be with the surgeons and the backup.
I don't know, you probably remember those days, but back in the old days when we started doing the interventional core valve, the risk of pacemaker, the idea is just you do a cut down, you get the TAVR, on the way out you put the pacemaker and you close the pocket. I mean, definitely
Much better now.
Much better outcome right now. But we as a center we're a little nervous about trying subclavian and percutaneous approach. It's a very fragile artery.
Sure, yeah, definitely.
And even with cut downs, we had share.
Because we saw like there was no calcium, everything was clean, and still had this complication from unexpected one. So it's not like expect.
So we just saw another one, so.
Oh, you did. Okay. Yeah.
I'm sorry, I think I saw in your article that maybe I misread this, 8.3%. Oh, I'm sorry, I did misread it.
Oh, okay.
Mortality, I'm sorry.
Oh, it's okay.
I
No.
want to ask that.
Sure. No problem. All right. Thanks a lot. Thank you.
Great.